Everyone, and welcome to today's session, How to Communicate with Parents and Caregivers About Suicide. I will now turn it over to Miss Alicia Henderson.
Thank you, Tamaria. Hi, everyone. Good evening, and welcome to the second session of our 2023 Pediatric Suicide Series. Tonight's session will be how to communicate with patients and caregivers about suicide. We're so excited to have you join us and hear from some of the experts on this topic. We're going to learn skills to help us lay the groundwork for communicating about suicide with families in the clinical setting. We have two presenters here today from the Children's Healthcare of Atlanta. Our first presenter, Andy Irwin, is an Atlanta native growing up in the nearby Gwinnett County. He had an early passion for healthcare that ultimately developed into a master's degree in healthcare administration. Andy currently works in healthcare finance at Children's Healthcare of Atlanta, supporting Children's Chief Financial Officer as a project manager. Andy's core passion within the healthcare nevertheless remains behavioral mental health, specifically the destigmatization of mental illness and addressing social determinants of mental health through community ingrained partnerships. His own mental illness struggle and recovery journey have founded and continue to guide this passion. Outside of work, Andy loves playing soccer, spending quality time with family and friends, and spending far too much money on escape rooms. Our second presenter, Erin Harlow Parker, has worked in the field of child and adolescent psychiatry for 35 years. She received her BSN from Rhode Island College and her MSN from Northeastern University in Boston, Massachusetts. Her practice areas have included inpatient, outpatient, consult psychiatry, and behavioral and mental health illness prevention work. Erin is currently a manager of child advocacy programs, behavioral and mental health at Children's Healthcare of Atlanta. Her passions include suicide prevention, treating patients with eating disorders, and reducing mental health stigma. She's actively involved in state behavioral health initiatives to improve the behavioral health needs of children in Georgia. In 2018, she was awarded the Institute for Healthcare Improvement National Patient Safety Daisy Award for Extraordinary Nurses. And I will hand it over to our two presenters for this evening.
Thank you for that introduction, Alicia. It is a real pleasure to be here with you all tonight. I know at the end of a long work day, it can be kind of exhausting to think about attending an educational training. So we appreciate everyone that has attended. As the introduction said, Andy and I are here today to talk to you all about how to talk to kids and caregivers about suicide. Some housekeeping. Neither of us have any disclosures. And just to have an understanding of what we hope that you all will get out of this training today is an understanding of the role that stigma plays in talking about suicide, understand how to set up a foundation for communication about suicide to occur in whatever clinical practice you're coming from, an increase in some skills for handling those challenging conversations with both kids and caregivers. So at this point, I'm going to turn over the presentation to my colleague, Andy, who will share a bit about his journey with mental health. And it really does tie beautifully into sort of how we then can think about framing conversations around suicide. So with that, I'm going to mute myself, advance to the next slide, and turn it over to Andy.
Fantastic. Thanks so much, Erin. And thank you as well to Alicia and the department for the opportunity to come and talk with y'all today. I really do appreciate it. I know that it gave a little bit of my background, but just to summarize again, my name's Andy Irwin. I am a coworker of Erin's at Children's Healthcare of Atlanta. I'm actually non-clinical. I work in healthcare finance. I'm a project manager supporting our CFO here at Children's, and I've been in this role for about 1.5 years and Children's for 3 years in total. Like was mentioned in my bio, my real passion in healthcare really is behavioral mental health, both a personal connection and then hopefully a professional passion as well as it continues to grow. I've been thankful enough over the past few years to get the opportunity to do this, to speak. Even more recently, over the past couple of years, I'm very thankful for some mentors and the Office of Recovery and Transformation within DBHDD, just really for their mentorship and coaching on how to craft this narrative. So I really do appreciate y'all's time. All of that to say, now let's get into that kid with the big head that you see down there. Um, a lot of stories that I could tell from this time period. I will say, just as a background, as you heard, I'm an Atlanta native, grew up in Gwinnett County. Um, to speak to my childhood broadly, I would say that I had very supportive, attentive, loving parents, a younger sister who I adored and still do. Really a broader family network within Atlanta that I was so lucky to have. Um, of course, our family isn't immune from the ups and downs of life, but I will mention, in terms of some of the protective factors, and as we discuss the social determinants of health at large, really a lot of the struggles I was largely unaware of growing up. I was grateful to be raised in a middle class family, attended private school throughout my time of elementary all the way through high school. Um, Again, can speak to a lot of stories. I think there's one that stands out in particular that I'll share with you, and it comes from fifth grade as I was transitioning to a new school just down the road. I can remember a lot from that week, a lot of the typical to-dos during your first week of school. One talk that stood out in particular to me was that classic disciplinary talk, which I'm sure we've all received. Going through the general rigor, and it was pretty standard. It would be first offense or behavior would be a warning. Second offense, you would sign the book and you'd sit out for a portion of recess. And looking back, and even in that moment, I really appreciate what a good job the teacher did from separating the person from the behavior, saying, hey, don't be upset. This is something that is going to happen to all of you throughout the course of the year. It doesn't make you a bad person. It doesn't make you a bad kid. We are all just learning and growing together. I went through that entire school year, and not only did I never once sign the book, but I don't think I ever received a warning either. And looking back, that was such a horrible thing to happen to me because, and I don't even know how it started, but somehow that set the expectation in my mind that I could never put a foot wrong. And as you all know, that's not me, that's not anyone. So as I progressed throughout school, I slowly and gradually progressed into these habits that I'll call perfectionism and people pleasing. And I saw myself, as time went on, I began to place more and more of my self-worth into what I accomplished and into how I made other people feel. And when you do that, of course, you knowingly or unknowingly put your own needs, desires, ambitions in the back seat. I really progressed in this way all throughout my high school career. Really into my college days was where I would see this come to its full fruition. And as we look forward, here are just a couple pictures about my college career. To speak to it briefly, at this point in my life, I was a biochemistry and molecular biology major with a 3.8 GPA. I was getting to present some of my research at international NATO conferences during that time. I also happened to be the captain of my university's men's soccer team. At this point in time as well, I was pursuing a professional soccer career. More than anything, I would say that I was well connected. I was involved in different organizations on campus. I had a good friend group and support system beyond that. And I was, in a lot of ways, well connected. I'm telling you all of these things, as you might guess, um, because looks are deceiving. Because I don't think a single person on that campus knew during this time that I was suffering from major depression and contemplating suicide. As I was beginning to craft this story, that question that you just saw popped up consistently, actually by a director at my former organization. She said, could someone have guessed? What did people miss? I want to take the time over these next few minutes to really go into the details and nuance, knowing just how nuanced and personalized mental illness can be at times, to talk about some of the signs that, for me in particular, might have indicated that things were just a little bit off in my world. So the first, I would say, is the distance that I created between myself and others. I classify myself still to this day as what I'll call an outgoing introvert. I really do value my connections and time with people. However, when it is time for me to recharge, I often do so in solitude, alone, to refill my battery. It was like at this point in time, I had a permanent depletion of my social battery that I can never just fully recharge. And so I would spend more and more of my time, not always noticeably, but isolated, in a word, retracting from those people that I cared about the most. This loss of energy and focus, as I'll call it, really delved more deeply into those areas that we just talked about before, whether it was academics, athletics, organizational activities. I saw my performance in the high bar I had set for myself so consistently become even more consistently unattainable. This really delved even deeper, if I were to describe my day to day, into really a lack of proper self care. I can remember some days at the height of my illness, almost like a regular pattern. I would wake up late for work or late for class, I should say. I wouldn't have time to shower. So I was living at the time at really just a pile of clothes beside my bed that I didn't have the time to clean properly. So I would rush to class, most often be late. And as I think about that time when I would go through my days, it was so structured to the minute. I would fill my day with all these activities because I had this deeper fear of saying no or of letting people down. And so I can remember going about my day with a structured plan that obviously not going to plan. And as I would go about, it almost became this cycle, I'll say, of self-shame, if you will. I would get home and I would say things to myself like, gosh, you didn't do your dishes tonight. Like, why are you being such a bad roommate? Or you didn't respond to that text. Why are you being such a bad friend? It really, in a word that you see there, became a bit overwhelming. And it is such a unique experience, I will say, from my experience during this time. Walking through campus, seeing people that you know and love and saying hi to them with a smile on your face. And internally, there's this sense of drowning, like you are just gasping for air, clawing within yourself while you go about your day. That same director that I spoke of showed me this quote, and I think it's so apt because it really did feel like at times while on campus that my body was revolting against itself. Within the Office of Recovery and Transformation, they use this great imagery of masks, and I'd become so accustomed to wearing masks of where I thought I should fit in and who I thought I should please and what I should accomplish, that it became very difficult sometimes to get to the true self of what was my identity? What did I really want? What did I really need on a daily basis? Now, as I fast forward, I don't know if there's a true climax to this story, but there is one day in particular that really stands out to me. And I think it gets its power, honestly, from being so commonplace and ordinary during that time. I can remember waking up, going to workouts. I went to my class. I went into research lab. After that, it was my organizational activities, then to soccer practice, then back onto campus to study. And I can remember walking across the heart of campus, just leaving the learning center, and I'm heading back toward my car, which is over near East Campus. And I'm not even actually going back to my car. I'm going back into my research lab to go under the microscope. And at this point in time, it's probably between 1 and 2 a.m. if I had to guess. And as I'm walking through the campus, what I'm looking at is actually what you're seeing right there. You walk across the bridge and our football stadium's lit up. And as I'm walking across the bridge and looking up, I make it about halfway and I stop and I look down and my hand is gripping that railing that you see so tightly that it almost looks like the blood has just left it entirely. I stopped in that moment. For the first time, I took a moment and I forced myself to acknowledge that there was a significant part of me internally that had thoughts of jumping off head first. In the week to go or week to come, I would say there are really two things that changed everything for me at that point. And they were small but powerful actions. You see on the left down there is my family, my immediate family, and on the right are some of my best friends still to this day, currently were my roommates at that time in college. It was a call that I made to my parents. I remember it was again late at night, and I was in my car in the restaurant, or the parking lot, I should say, of my favorite restaurant at the time. And then in a few days to follow, it was a text that I sent to my roommates. And all I did was open up and let them in, to let them know that something was not okay about the thoughts that I had and feelings that I had been perceiving recently. And honestly, without their support and understanding and their own courage, I don't know if I myself would have had the same courage to then go ahead and embrace the resources through our university's counseling and psychiatric services that were thankfully at that time for me well publicized and available. It is in what is to come since, as I will summarize briefly, I think it has been really a rewarding and totally imperfect journey in the pursuit of greater wellness. If we scroll forward once more, I wanted to talk about just a few things of what I continue to learn in my day-to-day now that I am years removed from that college campus in a totally different environment. The first thing that I continue to learn is that wellness is my responsibility. I think that, again, there are amazing support systems and structures and resources that were thankfully, again, available to me to help pursue me on this journey. But the decision, first and foremost, came from myself to acknowledge that something was wrong and to want to change. That being said, I do think that that foundation is irreplaceable. It is something that I continue to engage on my promotion wellness journey, whether that is medication management, a therapist, licensed therapist with whom I communicate, etc. I think that that creates the building blocks that can really propel me forward on this journey overall. With that, as I think about the story at large, and thinking about just my day-to-day conversations, something I am trying to practice is more authentic dialogue. I think that something my parents still do well for me to this day is we'll be on the phone and they'll say, "Oh, how are you doing?" And you give that sort of, I'm not thinking about this answer of, "Oh, I'm doing fine." They really have learned to take a step forward or take a step back actually and say, no, tell us how you're really feeling. That is a practice that I have tried to adopt with my friends to really get to the deeper meaning and deeper understanding of things in our day to day that can sometimes get so hectic. Ultimately, to conclude it all, it really does feel like something, again, that I'm bad at, but working at is a healthy prioritization of myself. And as I learn to adopt these healthy habits and attitudes, and as I learn to simultaneously be okay with learning some of the innate behaviors and attitudes and thought patterns that might not be serving me in the best way, that I'm continually becoming familiar with, having grace in that and prioritizing appropriately what is going to serve me better moving forward, and understanding that that journey in itself is quite difficult and ongoing and requires a lot of patience with myself, which hasn't always been the easiest, to be honest. So now, as I pass it off to the wonderful Erin, who will really get a chance to dive in to a lot of the skills and resources of talking about these types of conversations and stories that I'm sharing with you, there are a couple thoughts that I wanted to leave y'all with that I think were really applicable to this situation. The first that I wanted to speak to briefly is my own relationship with my pediatrician growing up. I absolutely loved my pediatrician growing up. It was a what I'll call a supportive and trusting environment, not only for me, but perhaps even more importantly to my parents. It was something that not only did I do my annual checkups, go in for perhaps an illness for further consultation, but my parents had really built up a relationship with my pediatrician to the point where they felt comfortable, especially with me as an early age, to call him with their questions and concerns and understand that he would perhaps not right away, but be able to get back to them and discuss things further with them and help quell their concerns. Despite all of this, all the great things that I could say, I don't know if throughout any of my visits we ever talked about suicide, if we ever talked about mental illness. I don't know if these were even conversations in a general sense I necessarily had with my parents, but perhaps a handful of times of growing up. And to be honest, I don't blame anyone. I understand that this is a difficult topic. I think that there is, again, still to this day, a lot of pervasive stigma, and there are a lot of misconceptions, I'll say, about these types of conversations that Erin thankfully is going to talk a lot about today. However, I will say that as I've gone throughout this journey and as I get to share this story, one of the things that I love doing the most is thinking about how, in a general sense, I get to impact somebody in my shoes, to think about if there's something that Andy in high school wanted to hear, what would it be? And as we think about this message and even our Strong for Life Raising Resilience campaign, one of the things that we say is that it is never too late, nor is it too early to begin conversations of resilience. The other thing that I wanted to mention just briefly, and I think it ties in well to our earlier webinar, actually, related to screening assessments. I will say just briefly that a screening tool, again, thankfully, was made available and publicized on my college campus. And it was something that I utilized and was foundational in my journey. Those results really grounded me in a different understanding of my reality. Sometimes it's so easy to think that what you're experiencing is normal when the data will show you otherwise. And I think that this is something that was really, really crucial to me to help build a bridge to that ultimate conversation that I had with my parents and with my friends. So as we think about as well having these types of conversations, what are the different bridges in place that can help be built to make it easier to have these types of conversations and realizations and understanding? Again, a very complex topic, but something that I'm glad that Erin's going to get to speak to as well today. So with all of that, I really do want to thank you for your time, and I will now pass it off to Erin.
Thank you so much, Andy, most specifically for your vulnerability and bravery in sharing your very powerful and compelling story. As long as I've been in this space, I do think that it's incredibly powerful that we look for opportunities to hear stories from people with lived experience that really can ground us in the work that we're doing. Because at the end of the day, we're here for the people we care for and the patients we are taking care of. But we can best learn from them as we sort of partner along their side. So again, thank you. So we're going to start with, why is it so challenging to talk about suicide? What causes us such significant stress when we hear this word, both as clinicians, as family members who have had loved ones struggle with suicide? Why is it that we struggle with being able to talk about this openly? So we know there's often a lot of embarrassment around this. And the embarrassment has a lot to do with that stigma that Andy addressed. We know that there are a lot of negative perceptions related to suicide, such as that suicide is a weakness. And so if that's a perception that someone has that may be struggling with thoughts of suicide, that it's their fault, they should just buck up, suck it up. If a family member thinks that of another loved one, they're going to be less likely to seek help and talk about it. We also know that there are thoughts that someone who is thinking about suicide or someone that has died by suicide is selfish. And you can see how that would prevent someone from wanting to talk about it. We also know that people don't know what to do next, or they don't know what to say next. There's a lot of fear related to suicide, and we're going to talk a little bit about what this fear comes from. A lot of it is around those misconceptions. Thoughts about, what if I make it worse? If I don't know what to do next, and I don't know what to say next, then I might make it worse. And we know that there's a lot of shame associated with mental health in general, but specifically suicide. And that shame is associated with those who themselves are struggling with thoughts of suicide because of all those things we've just talked about, but also families who have been either left behind after someone has died by suicide. What did I do wrong? What could I have done differently? As well as those who have been struggling with suicide and not wanting to talk about it, not seek help because of that shame. We know that there are many common misconceptions. These are just a few that I have definitely heard throughout my career. The first is that anyone that tries to kill themselves must be crazy. What we know is that there are those who struggle with thoughts of suicide or that die by suicide who actually don't have a diagnosable mental illness. And that people who talk about suicide really won't do it. If they're talking about it, they're not going to really do it. And as a result, we don't take it seriously or we dismiss it. I will say that this next misconception I've heard a lot in my pediatric psychiatric career. Talking about suicide may give someone the idea. Because a part of my job at Children's early on, I've been at Children's 16 years now, was on the psychiatry team. So doing suicide risk assessments was commonplace. And of course, I would always let parents know sort of what they would expect in an interview. I prefer to interview the child alone, but often parents really struggled with a mental health professional interviewing their child, and even more so with being asked, having direct questions around suicide because of this misconception. And in fact, what we know is there is no research to support that talking about suicide, educating about suicide, screening for suicide is going to give someone the idea. Another misconception is that if a person is determined to kill themselves, there's nothing that we could do to stop it. Instead, what we know is that messages of hope and connection and that someone is loved are incredibly important and can be prevention methods. And the last one is that people who die by suicide are people who are unwilling to seek help. But instead, what we know is that because of all of these misconceptions and stigma, often the person who's struggling internally struggles quietly, doesn't know how to ask for help, doesn't know what to do, doesn't know what resources are out there, is filled with shame. So if we can shift that paradigm and move to a place where we begin to sort of talk openly about suicide, letting people know and educating people about help-seeking behaviors, we can really dispel a lot of these misconceptions. So I want to talk a little bit is how do we talk about suicide? And first, we're going to start from a place of what are the words that are stigmatizing that we still hear about? I mentioned, or it was mentioned in my bio, that I've been in this space for 35 years now. And I can say that as a mental health professional, these words that we are now listing as stigmatizing terminologies are actually words that we used in my profession early in my career. So things like committed suicide, successful suicide, completed suicide, failed attempt at suicide, and unsuccessful suicide are truly terminology that we should no longer be using, that are incredibly stigmatizing. When we think of things like committed suicide, the word committed is often associated with crime, things that have many, many negative connotations. Successful or completed sounds like it's something that you should be doing. So we certainly want to move away from that stigmatizing language and instead use more appropriate terminology that is person first. So a person who has died by suicide, a person who has suicided, a person who has ended their life, a person who has taken their life, a person who has attempted to end their life. And you may have noticed, I have certainly noticed in the last year or so, a more intentional, purposeful use of this appropriate language in the media, whether it be the news, print, in lectures. But I do continue to hear things like committed, most often is what I hear. And I have no problem using it as a teachable moment and educating someone on what is the most up-to-date and appropriate terminology. And I have never had anyone offended by my correction, especially if I've done that in an empathetic and a compassionate way. So Andy mentioned in his talk so many themes throughout his journey through recovery around sort of prevention efforts and messages that were sent to him. And the idea of sort of setting this sort of foundation, starting frankly at birth. And we in the pediatric space have this great opportunity in our day-to-day interactions with youth and families starting at birth to sort of start with this prevention approach, which basically will set this stage that allows an opportunity for that youth and the family to feel okay talking to us as pediatric clinicians, specifically in the medical field, about things like suicide or emotional wellness. So that starts with creating this welcoming environment. So this is something that I do day to day in my work at Strong for Life and providing this training to pediatric primary care practices around building resilience. But in addition, I did a little more research and came across this unbelievably great resource, which is listed at the end of the presentation, from the American Academy of Pediatrics and the American Foundation for Suicide Prevention in collaboration with behavioral mental health experts from the NIMH. And they created this blueprint for youth suicide prevention and educational resources specifically for pediatric health clinicians. And in that, they sort of reinforce this idea of starting from creating a welcoming environment. And what this does is it asks the clinicians and the staff in your pediatric practices, whether that be in primary care, acute care, subspecialty spaces, to reflect on your own biases, specifically related to mental health. To be really mindful that you're using inclusive and respectful language and imagery. So think about your clinical practice as things like the artwork on your walls. What does that look like? Is that reflective of the community that you're representing? Asking patients about their names and pronouns and using them consistently. And utilizing those trauma-informed principles that support and promote relational health. You heard Andy say time and time again throughout his story, the importance of relation and connectedness. What trauma-informed principles talk about is that it encourages patient and family empowerment. It creates that sense of physical and emotional safety. It encourages collaboration of care across the continuum of care. The other things we can do sort of from a prevention space is that we can promote emotional expression. And we can do that with all kids starting at birth by teaching them how to identify and label their feelings. This is not something that we're born knowing how to do, right? That's when infants don't have those words, we speak for them, and we do a pretty good job as humans in the lives of infants. But as they grow and develop into bigger humans with more vocabulary, we stop helping them figure out how to identify and label their feelings. But what we know is that feelings are super complicated. There's more than just happy, mad, sad, scared. But those are the feelings we tend to default to. So these are resources that you can see on the right hand of the slide that we've created at Strong for Life that are located on our website that you can print out. And if you take one of our trainings, you can have access to these for free and sent to your practices. But they're great opportunities to help kids label and identify feelings. And if you don't feel comfortable even doing that, simply hanging them up in your practice says, hey, everybody has feelings and it's okay to talk about them. And we want to encourage families to look for opportunities to routinely and openly talk about feelings, starting at birth. This is something we do in our family. We talk about it all. We can utilize the beautiful I wonder statements. I will say that in my career, I didn't learn about I wonder statements early on. This has been a new phenomenon for me in the last 5 years and a pivotal tool for me to use. I wonder if you can look at this poster and tell me how you're feeling today. What this does is it allows opportunities for curiosity. It allows opportunities for self-reflection. It makes sure that I'm not telling someone how they feel. Other things we can do to promote emotional expression, both in our clinical practice, but also model for caregivers to utilize at home, we can utilize open-ended questions. It offers that child that opportunity to share more information. Things like, what's been the best part of your day, or what's been the hardest part of your day? Avoiding things like, you don't ever feel sad, do you? When I say, you don't ever feel sad, do you? That's definitely sending a message to the child. I don't really want to know if you're feeling sad, right? And it really is coming from a place of us feeling uncomfortable with, what if they tell us sad? What do we do with that? But instead saying, how often do you feel sad? Because what we know about sadness is that everybody feels it. So when we say, how often do you feel sad? We're making that assumption that that child feels sad because it's normal and okay to feel sad. We're going to employ active listening because we know this conveys empathy. It demonstrates respect. It encourages you to withhold judgment and advice. It helps the person feel valued and accepted. And it's super simple. It's coming in, it's sitting down, it's leaning in, uncrossing our arms, nodding along. And we can utilize reflective listening because it conveys that sense of presence and it repeats back what you hear. So if a child says, I didn't have anyone to sit with at lunch, it was so embarrassing, I can reflect back and say, it sounds like lunchtime didn't go as well as you hoped. Is that right? I'm clarifying that. I love reflective listening in pediatrics because I'm getting history from both caregivers and kids. And sometimes I'm getting a lot of information and I want to make sure I get it right. And so I'll reflect back what I heard and ask them to clarify. It allows an opportunity for that person to also hear what they heard and add more information and clarify. Other ways we can promote emotional expression is we can normalize, we can validate, and we can allow all feelings. The allowing all feelings is incredibly powerful. It's moving away from that place where we categorize feelings as positive or negative, good or bad, and instead of they just are, and we expect you to have an array of feelings. So saying something like, I can understand why you might feel that way. I've had that happen to me before too, and it's normal to feel embarrassed. So that lunchroom scenario, right? We've all had that in our lives. So normalizing and validating for that child helps them feel seen and heard. Also saying that it happened to you humanizes you and instills that sense of connection. So when we think about that prevention approach, this sort of universal way in which we set up our clinical practice, starting with all kids at birth, we're both showing children what it looks like and modeling it to caregivers. We're going to encourage that emotional expression. We're going to teach proactive use of coping skills. And I say proactive use of coping skills because that means we're going to utilize that with every kid that we're working with, starting at birth where we're teaching families about coping skills. And that may be just things like family walks at the end of the day. That may be that we do a yoga class together. That may be that I give them a teaching tip on how to do deep breathing. I'm not waiting for the stress or the crisis to occur to give the skill. I'm teaching it proactively. I'm going to educate on mental health and mental wellness. Notice I said mental health. I didn't say mental illness. About how do we keep our mental health in check? What are the things that we need to do? Well, basically, we need to promote our healthy habits, right? So we easily talk about the importance of sleep, nutrition, and physical activity, but do we intentionally make those connections between our physical and our mental health? When we do that, we're educating on mental health and well-being. So we want to also educate kids and caregivers specifically about suicide. We want to emphasize hopeful messaging, ensuring that they know that they're not alone and that there is help out there. If we're a practice that is screening universally for suicide, we're going to explain why it is we're doing that. We may say something like, at our practice, we screen every child from ages 10 up annually for suicide risk because we know in this age population of 10 to 24, it is a concern and we take it seriously. Or if we don't screen universally, but we screen for, say, depression, and on the PHQ-9, we get a concern for suicide, which leads us to ask more specific questions or utilize a screening tool specific for suicide, we explain the why behind that. We're intentional in educating populations on risk factors, the protective factors, and what the warning signs are. We're being mindful that we use age and developmentally appropriate language. This is a big one. We want to avoid inserting your own fears or judgments when talking about suicide. And this is hard when we don't feel safe and uncomfortable and we don't feel like we have all the answers. And instead, we sometimes can maybe default to things unintentionally harming, but are things like, you don't ever think about suicide, do you? Right? Our intention isn't to be judgmental. It really does come from a place of, oh, I don't feel very good about this, and I don't really know how to say it. So I'm going to say it this way. When we're working with kids specifically sort of middle school on up, we want to really be clear on what confidentiality limitations are. So when I assess a child, and I always assess for suicide, before I even begin my assessments, I talk about what the guide rails are for confidentiality. What you say to me will stay between you and I, with the exception of things to do with your safety or the safety of others. We're going to be intentional in starting early, asking often, and being direct when it comes to suicide. We're going to talk a little bit about what that might look like. So as we move into this next section, we're going to talk specifically on 3 sort of different groups of youth that we may come in contact with regards to risk. So those kids that are at imminent risk, those kids that are at sort of moderate risk, and those kids that are at low risk. And if you were present for Dr. Lamus's presentation on suicide screening, where he talked about suicide risk, protective factors, screening, risk assessment, lethal means counseling, referral, and documentation, you also would remember that he categorized risk assessment in those sort of categories of kids that are at real high risk, those kids that are at moderate risk, and those kids that are at low risk. And so we're going to go through, how do you talk to youth in each of those categories, and subsequently, how do you talk to the caregivers in each of those categories? So that first group of kids are those that are at imminent risk for suicide. So when we're going to talk to those youth, we're going to always start from a place of listening without judgment. We're going to employ that active listening that we talked about, that sitting down, leaning in, nodding along. We're going to always validate and normalize their feelings and experience. We're going to be really clear on what is the confidentiality. What are those guardrails on confidentiality, right? We're going to let them know what to expect next. So if we've determined that this child's at imminent risk, we're going to let them know what the next steps are. And that includes partnering with them, which is that trauma-informed approach, and how they want their caregiver to be informed. Do they want to tell them with you sitting beside them? Would they prefer that you tell them with them? Or would they prefer that you tell them without them in the room? And I've had all 3 of those scenarios that kids have felt comfortable with. We want to be really clear that we're going to praise that child for sharing such a hard thing to say, with something like, thank you for sharing your thoughts with me. It can be hard and scary to share thoughts of suicide. And I want you to know that I think you're very brave, and I'm here to help you, and you're not alone. You can say things like, I'm going to have your dad stay in the room with you while I step out to make arrangements to get you some more support today. That's letting them know what to expect. Then when we're working with the caregiver, we want to be thoughtful about that our words matter. We're going to be really mindful of avoiding language that places blame or makes caregivers feel guilty. Simple things like that we may not even realize that could make them feel guilty is like, did you know about this? Right? Our intention is maybe probably to gather more information, but stating it in that way does leave the caregiver to feel taken aback, like they did something wrong. And I can tell you they already think that. So we really need to be very mindful as we're gathering history. We're going to employ active listening. Tell me a little bit about what you know about this. We're going to validate and normalize this feeling and experience. I can imagine this is really hard to hear. I'm going to be with you along this journey as we ensure that your child is safe and taken care of. We're going to be really clear on what the next steps are and the plan. And that might be different depending on your clinical practice. Your practice protocol may include calling the Georgia Crisis and Access line and waiting for a mobile assessment team to come out and do a further assessment. Your clinical practice protocol may include sending that child by ambulance to an emergency receiving facility, whether that be a psychiatric inpatient unit or an emergency room. But we want to be really clear on what the family and the child should expect. We're going to be ensuring connecting to care, and that includes a follow-up phone call to check in with the family on what happened with the assessment and how they're doing. And Dr. Lamus addressed lethal means counseling. Even though this child is moving to the next level of care, it is still incredibly important that you play a role in lethal means counseling. And what that means is that you are talking directly about asking questions of whether there are firearms in the home, how they are secured, and if the family is willing to remove the firearms from the home during the time of risk. In addition to firearms, however, it is also important to understand prescription medication and over-the-counter medications, and encourage families to put those in a locked location, which means a lock, not just hidden up high. Those are the kinds of things that are involved in lethal means counseling. The next category of youth are those that need further mental health evaluation. And this is the child who is having thoughts of suicide but does not have an active plan or access to means. Notice that we're going to employ those same first steps that we did in the child with imminent risk. We're going to listen without judgment. We're going to employ active listening. We're going to validate and normalize their feelings and experience, praising them for their bravery and willingness to talk openly about their experiences. We're going to explain that confidentiality, which is incredibly important. We're going to tell them what to expect next. And we're going to come up alongside them, that trauma-informed approach, and partnering with them on how they want their caregiver to be informed. That same sentence stem, those two sentences that we used in the imminent risk, we will utilize in this child as well. When it comes to the caregiver and how we talk with them, again, those initial steps of our words, avoiding language that's blaming, employing active listening, validating and normalizing, we will do in this situation as well. The clearly informing of next steps in the plan may slightly change. We may have in our practice protocol that we will give a referral to an outpatient therapist, or if the child's already in therapy, we've called the therapist. It's important to give the National Suicide Prevention Lifeline. You'll see that listed on the right hand of the slide. In our state, we also have the Georgia Crisis and Access line. Additionally, at strongforlife.com, we have, and if you hold your camera phone on to this QR code, it'll navigate directly to this article on firearm safety, which is a beautifully outlined article on how do we have intentional conversations around safe and secure firearms. Additionally, we have resources for you on behavioral mental health services that are incredibly helpful for families who may be naive to the mental health space and aren't aware of the different kinds of clinicians that are in our space or the kinds of therapy that are used in pediatrics. The front of that page addresses that. The back of the tip sheet addresses, hey, what kind of questions should I be asking as I look for a therapist for my child? And then once my child's in therapy, what should I know about it? We want to again have that lethal means conversation. And then if this is part of your practice protocol, and Dr. Lamus addressed this, employing a safety plan. I'm going to talk again. I know that Dr. Lamus went in detail about this, but I think there's never any harm in emphasizing this again about what is included in a safety plan. And again, I appreciate in the pediatric primary care space, this may not be something that you are at a comfort level yet, but this may help spark some curiosity as you think about your practice protocols and what you might be willing to put in place. I want to be really clear that a safety plan is not a safety contract. It's not a legal document. It is simply a safety plan of care that, again, utilizes trauma-informed principles in that you're partnering with the child predominantly, but coming up alongside the caregivers as well. And what this safety plan does is that it ensures that the child addresses what are the warning signs? What do I know about me that tells me that a crisis may be developing? What are some coping strategies that I can do on my own? Who are some people and social settings that give me those distractions that can take my mind off these sort of passing thoughts? And then who in my life can I ask for help? And these really should be the trusted adults in the lives of kids. I'll tell you, I've used the safety plan. This is something we have at Children's that we've adapted. This is a safety plan that a researcher or a psychologist developed that many people have adapted for their organizations. But often kids want to list other adolescents on there who they can ask for help. I always encourage them to list at least 2 adults, and we talk through that. Then we list out some professional agencies, and then include that Suicide Prevention Lifeline and the Georgia Crisis and Access Line. Step 6 is that lethal means counseling. What are the things in my environment I need to do make it safe? So this is where I have those intentional conversations around firearms. Do they exist in the house? Are they secured? How are they secured? And is the family willing to remove those from the home? And then medications, how are they secured? This last one is a really powerful protective factor. What is something that is the most important to me and makes life worth living? I'll tell you, there's many times I've done the safety plan, that last sentence is incredibly powerful self-reflection for that child. And then everybody signs it. And we make sure that the child has it, the caregivers have it, and I keep it in the file. And then the last category of kids are those that are at low risk for suicide. So these are kids with remote histories of suicide who may have screened positive for a mental health concern like depression or anxiety, which we know puts them at higher risk for suicide. So we want to be really intentional on educating on those protective factors and pointing them out. You heard in Andy's story, he had many protective factors. His family, his friends. I would argue that his personality of being driven, while sometimes it may have worked against him, it also was a protective factor. We want to be talking early and often, and we want to be validating those feelings. With the caregivers, we're going to do those same things. We're going to educate on risk and protective factors. When we talk about protective factors, we want to help families understand what are those individual protective factors that child has, that the family has. What are those relationships that they have that are protective factors? What in their community are those protective factors? Organizations that they belong to that have a sense of connectedness to? And are there any of those societal protective factors, like reducing risk to lethal means? Even frankly, cultural, religious, or moral obligations to suicide can be a societal protective factor to reinforce. We're going to give mental health referral options if indicated. We're going to talk early and often. We're going to provide specific resources to caregivers on how do you talk to youth about suicide. And again, we're going to employ that lethal means counseling. So as we begin to wrap up, I wanted to take a moment to be able to give you all some information on how do we talk to kids after someone has died by suicide, maybe after someone has been talking actively about suicide, or after a suicide attempt. And this information comes from a great resource from the University of Utah Health. So when we're thinking about talking to youth about suicide, we always want to start from a place of asking them what they know. And we always want to let them lead the conversation, basically answer only the questions that they have. So when we think about the younger population, we're going to keep it simple. We're going to keep our answers short and to the point. Something maybe like the person had a disease in their brain and it took over. Talk about it like any other health condition. They died and it's very sad. And following their lead and only answering the questions that they ask. As we move into that sort of elementary age, sort of 2nd to 5th grade, we're going to be honest. We can give a little more detail, but we're going to continue to keep our answers short and simple, continuing to emphasize that the individual died from an illness and that the death was sad. It's critical that we encourage parents to follow the child's lead and answer their questions truthfully, while being careful, of course, not to provide them with too much information. So something like James had a disease called depression, and he had it for a really long time. And I wish he would have been able to get more help. When they get to middle school, we can include more information and details. We can ask them what they know, what they've heard, or what they know about suicide, or what feelings they have about it, what they believe to be true about the causes of suicide. In doing this, we're doing a few things. We're creating opportunities and conversation that talking about suicide is okay, but we're also gathering information from that child that allows opportunities for us as the adults in the lives of kids to correct any misinformation and enter the conversation where they're at. So we can explain that a person who's died by suicide, it's not their fault. By the time they get to high school, unfortunately, many teenagers have known someone directly who has either died by suicide, has attempted suicide, or has had thoughts of suicide. So we want to continue to have open conversations about suicide. But at this point, they need to know what to do when they or a friend have thoughts of suicide, because it's more likely to occur. So asking them what they would do if they had thoughts of suicide, or if they had a friend that had concerns for suicide. It's really important that at this point in their lives that they know that depression and other mental health conditions are not from a person being weak or a lack of willpower, but that it is an illness that can be treated. And that they make sure that they know that help is available, and most importantly, that they can come to you and talk to you about it. And we really want parents to feel empowered to do that. We really want parents to send messages that that having a mental health condition is normal, and that they could ask for help. So I mentioned at the top of my section that I have a lot of resources for you, and I'll make sure that Alicia gets this to you all. These are some things I found along the way that I think are particularly helpful. And as we wrap up, I also want to highlight some toolkit items that are specifically developed and intended to build resilience in all youth. And we know that resilience is a powerful protective factor for suicide prevention. So we have developed things like coping skills and feelings posters that can be put up that normalizes that feelings and coping are things that we prioritize. We have these resilience tip sheets that are designed by age and development. And we have ones that are specifically for primary care that go along the well child visits, but these are the ones that are available on our website. And then we also have coping skills tip sheets that can be printed out as teaching sheets. Also, you'll notice a link if you want to sort of take a screenshot of this. This navigates to our clinician page, where you are welcome to sign up for any of our resilience trainings that are geared towards the primary care setting. And if you take a training and a good amount of your practice has participated, you can get a lot of these toolkit items delivered directly to your practice and utilize. Additionally, we have a campaign that we're in the second year of called Raising Resilience that you heard Andy speak of. Actually, Andy's story of resilience was one of the ones featured this year on our YouTube series. We also have Tyler Mazik, who you can see on the left-hand side, talking about his struggles with anxiety and how he navigated that and drew upon resilience. I encourage you to encourage families to navigate this. We have a great newsletter that comes out monthly that has digestible, actionable nuggets that families can employ resilience building skills starting at birth. Again, reinforcing those protective factors against suicide.
We want to thank them so much for sharing this information. It's been a wonderful presentation. I hope that you were able to take notes. I hope that you got a lot of resources. And again, if you have any questions after the webinar this evening, please don't hesitate to reach out to myself, to the learning department, or to Andy and Aaron. Thank you so much for joining.